My name is Frank Arko. I'm a vascular surgeon at Atrium Health, Chief of Vascular and Endovascular Surgery for one of the largest healthcare systems in the United States. I'm going to talk about our evolution in the management of heavily calcified disease in both aortoiliac occlusive disease, as well as challenging anatomy for access to EVAR and TEVAR. I'm going to go over sort of what we've done in the past prior to the initiation of Shockwave, and then we've got three other speakers who will be joining us on this webinar, Dr. Armstrong, Dr. Mazen Fote, and Dr. Andrew Holden from New Zealand. Again, I'm going to be speaking on just how I've evolved. I will say that we use a fair amount of Shockwave. The others are going to speak to how that's improved their outcomes and the ease of the procedures, and I'm just going to sort of compare and contrast what we've had to do in the past. So we know that challenging iliofemoral access for EVAR as well as TEVAR can be somewhat challenging. Our devices over a period of time have really not decreased that much in French size, although we've had some decrease, but certainly not at the same level as what you'd see in TEVAR procedures. So EVAR and TEVAR, if we can perform with percutaneous access, we know it reduces our operating room time, overall length of stay, as well as access complications and cost. Oftentimes we can do these, but when the disease is associated with calcified or narrowed iliofemoral arteries, these can be associated with rupture, dissections, as well as thrombosis. We oftentimes have to use adjunctive procedures in around 10% of the patients undergoing EVAR and up to about 21 to 30% of patients undergoing TEVAR. Now, on the last several years, maybe in just the last year, we've had some reduction in the number of TEVAR devices, but they're still typically larger than our EVAR devices and are some of the largest devices that we have to implant from a percutaneous type access component. Shockwave has safely modified some iliac artery calcium and can help to avoid some of these adjunctive procedures and simplify the challenges of calcified iliac access using these large bore devices, and my other speakers are going to go over that. So prior to this, what did we have to do? And if you're not using Shockwave, what are some of the types of adjunctive procedures that you're going to have to do? Well, one of the more difficult but giving you the best access is iliac conduit access. But we know if you do these, whether you're doing an open access procedure or an endoconduit, this is associated with increased mortality, morbidity, operative time, hospital length of stay. And if you're using endoconduits and the covered stents, oftentimes you need to use more than one. That really increases the cost of the procedure. And then when you're doing these on the TEVAR procedures, you typically have to cover the internal iliac artery, which you want to try to avoid in TEVAR because that can certainly be associated with an increased risk of paralysis, which is a dreaded outcome for both the patient as well as the practitioner doing the procedure. If you're doing these on EVAR, this often will lead to buttock claudication as well as pain that I oftentimes find doesn't necessarily resolve in the patients that we're treating. It does leave a permanent implant, which can oftentimes limit future treatment options as well. If we use these adjunctive access procedures, we can typically get them done percutaneously or with just a femoral cut down, but again, it's really going to increase the length of stay as well as the cost of the procedure. If you take a look at the cost of the procedure, if you're using implants, if you can limit that down to 2, that's going to significantly increase that cost of that procedure. Those stents can range somewhere between $3,000 to $3,500. This will oftentimes require an extra amount of time to do the procedures, and can oftentimes require a staged or multiple procedures. When you're taking a look at EVAR or TEVAR, these have a set DRG, so even if you're treating the aortoiliac occlusive disease, the cost of this procedure really goes up significantly. and ends up being a money loser for the hospital. So if we can try to minimize these implants or minimize the time and decrease the length of stay, we can really improve upon that DRG and make it a profitable procedures. So this is just a first case we're going to go over. This is a TEVAR, typical patient that you have, 82-year-old female with multiple penetrating aortic ulcers. That right there tells me that her comorbidities are going to be multiple. The ulcer that's causing her the most pain is really the ones down at the bottom, but you can make an argument for that entire aorta requiring to be covered. Now, again, with all these comorbidities, those PAUs, you can imagine what her aortoiliac disease is going to be like. I find that these patients with symptomatic PAUs typically have just terrible aortoiliac occlusive disease, and the access can be quite challenging. So when we get to this next slide, you can see here that the right and the left common iliac arteries are calcified. There's narrowings. There's narrowing at the aortic bifurcation. And then furthermore, the external iliac arteries are small, and not only are they small, they're mildly or moderately tortuous, but there's a fair amount of calcium throughout there as well. You can see here when we just put this sheath in over on the right side, that's a 12 French sheath, that sheath is almost occlusive to the external iliac artery on the right side. So how can we take these calcified and heavily diseased vessels? Well, in the past, in a patient like this who's old, symptomatic PAUs, I really want to try to limit any surgical procedures on these patients. One, to improve the speed of the procedure, and then also if you use conduits and you have to do a lot of coverage of the thoracic aorta, that really puts these patients at risk of of spinal cord ischemia. So what we did in this patient is actually use an atherectomy device utilizing the jet stream. This requires us to go from an 035 to an 014 wire. We made 3 passes with this through the external as well as the common iliac artery, just really trying to smooth out that calcium throughout. What we're trying to do here is really minimize the use of endoconduits and keep this just femoral access, and try to reduce that cost. Here you can see then ballooning of the right common iliac and external iliac arteries with a 10x4 and 8x6 millimeter balloon to basically treat all the outflow on the distal end. You can see here insufflation of the right external iliac artery with a 7x120, and then we stented the right common iliac artery, the right external iliac artery with a 10x4 followed by an 8x6 self-expanding stent. The reason we chose the self-expanding stents is one, decrease the cost of the procedure. Number two, the self-expanding uncovered stents preserve that internal and minimize that risk of paralysis. So here you can see the follow-up in this patient. We've got nice results. Access remains open. There, here you can see the TEVAR coming through. We've got the stent graft in place, and the large PAU is then excluded, and the access remains patent. Now here, this is the dreaded complication. This is the TEVAR. So again, this is going to 6.7 millimeters. You can see it sort of drops down. It's a thoraco-abdominal, extending all the way down to the renal arteries. Small external iliac artery is going to require a 24 French delivery system. The iliac artery is just measuring 7.5 millimeters. Here's the aneurysm coming down. You'll see it on the CT scan, extending down right to that level of the celiac. So we'll go to the stage repair and the access here. This is just a case where the vessels are calcified right at that aortic bifurcation. We're going to do a stage repair here. So we actually did a aorta to superior mesenteric artery bypass with a 14x7 bifurcated graft. So one to the SMA and one to the right renal. That was coming off the abdominal aorta. The celiac and SMA had previously been bypassed, as well as the right and the left renal arteries. When we came in here for this stage repair, we did balloon angioplasty of the right common iliac artery with a 7x60 balloon, insufflated for 3 minutes, and then sort of conduit onto the aortic bifurcation so that we could get up through this sort of smaller vessels through here. Problem with the conduit is, one, it takes a fair amount of time to put in, and frankly, a significant amount of morbidity for that patient. We did that because the external iliac arteries were small. We thought we could get the devices through the external iliac artery, but with the heavily calcified common iliacs, I just didn't think that I could get through the externals as well as the common. So I thought I could really just sort of then push and then daughter through the common iliac artery if I had no narrowing of the externals by doing the conduit. So here we've got a nice neck just to the left subclavian artery. We're bringing the device up. This looks to be a Gore excluder. We're bringing up to the left subclavian, and then we'll stent all the way down to that celiac artery. So here you can see we bypassed distally. These are large bore devices. We're going to extend those all the way down, and then basically completely fix this aneurysm from that left carotid, or left carotid, all the way down to the infrarenal aorta. So again, this is 32, 32, 150, 34, 34, 200 at the left subclavian, and then bridge that with a 34, 34, 200. And then we had a nice complete exclusion of the entire aneurysm. Here you can see the access repair. So the right common iliac artery, again, measured 7.5, no evidence of dissection, therefore it wasn't stented. The graft was then oversewn with the 4-O-proline, and then large clips were placed, and this was found to be hemostatic. So basically just bypassed it onto that external, to the iliac bifurcation, and then kept that internal preserved. I just thought that if I used an endoconduit or mucked up this iliac bifurcation and lost that internal, this patient would be at a very high risk for spinal cord ischemia. So again, here you can see the follow-up, complete exclusion of the aneurysm. You can see the conduit with the clips tied off on that 3D reconstruction. This is another patient. As you get into the aortoiliac occlusive disease, just the difficulty with management of these patients. So this is a claudication, going to require iliofemoral bypass and kissing iliac stents. You can just see how calcified these vessels are, multiple comorbidities, and just severe calcification. Doesn't look that bad on the axial images, but if you see this on the 3Ds, it's just absolutely terrible. Some of the worst calcium that I've ever seen, both in the right and left common iliac arteries. So what we did on this, basically did right and left common femoral end arterectomies. I actually had to do iliofemoral bypasses, and then had to basically attempt to try to crack that right and left common iliac arteries just with covered stents and high pressure balloons. We're able to successfully do that, but not without some fear and consternation of tearing that aortic bifurcation and putting him at risk of rupture. The problem is maybe he would have been better served with open surgical repair, but he just didn't really have anywhere to clamp on that abdominal aorta. We eventually treat him. You can see again just how bad this calcium is and how hard it was to access that and cross it. Not only crossing it, but then treating it with the current technologies that we have. This is again what we did: bilateral SFA end arterectomies and femoral end arterectomies on the right side. The end arterectomized segment was extremely friable, so we actually ended up doing a iliofemoral bypass on that side. Actually had to stent him with a Biobond stent, and then sew the bypass to that Biobond that we then end arterectomized that external iliac artery. We then did an end-to-end anastomosis and then reinforced that with a Biobond that extended into the external iliac artery on the right side. Here you can see we actually ended up getting a nice result, but this took a significant amount of time for us to manage all that calcium with a variety of different techniques, with not to mention a fairly significant blood loss because it was just so difficult to control the calcified vessels. But overall, a nice result. Here's the completion angiogram that we got. This looks like it's a nice, simple, easy case, but with the surgery that we had to perform, the difficulty with managing the calcium up top, this case actually took us about 5.5 to 6 hours to completely complete. So in conclusions, there are a variety of techniques that are currently used to address access-related issues with aortic repair. We can minimize the patient impact and maintain good blood flow. That's imperative. However, these techniques are somewhat limited to being used, and understanding these is important for deciding what is best. I mean, can we just daughter? Can we do ballooning? Can we use covered stents? But you really have to take a look at the entire patient, especially when you're taking a look at EVAR and TEVAR. And certainly having technologies that minimize these risks and these costs of these procedures is certainly warranted. And I do think that Shockwave presents a novel approach to addressing access, which may reduce the need for adjunctive stenting and other techniques which are costly, time-consuming, and put patients at significant risk. And with that, I'd like to turn the next talk over to Dr. Armstrong.